Good evening, everyone. It is our pleasure to welcome all of you to our latest digital symposium, proudly hosted by Veiva Scientific. This scientific platform aims to bring together leading experts to share their personal approach, clinical insights, and real world case experiences on the critical aspect of plaque modification in coronary interventions. We are honored to have all of you with us here today as we discuss this ever important expert strategies for optimal plaque modification. Before we begin, I'd like to say it's our privilege to host a reputed panel of interventional cardiologists from all across India. I would like to extend my gratitude to our esteemed panel of moderators, expert panelists, and speakers for joining us here today. Now, to take us through this evening session, we have the pleasure of having Dr. A.B. Mehta sir and Dr. D.S. Chadda sir. Thank you, Chadda sir, and A.B. Mehta sir as well for taking the role of moderators for this evening. Without waiting any further, I now hand over this platform to Dr. D.S. Chadda sir.
Thank you, Gauravi. I think plaque modification is really important in the current era where we get to see a lot of calcific coronary artery disease. And along with calcium, we also see a lot of fibrosis. So if you don't prepare the plaque well, your stent expansion is going to be compromised. And if that sets in, your long-term results are going to be poor. So very happy to moderate this important session. And we have a very eminent panel here. My co-moderator, ABM sir, is yet to join. And it's a very nice panel. And I would request all the panelists who are very, very experienced and they are masters in themselves, Dr. Sangatuvel, Dr. Barua, Dr. Prashant Jagtap, Dr. P.K. Sahu, Girish Navasundi, Karthik Vasudevan, and Saurabh Mehrotra to actively take part in the case discussions. We'll have 4 cases. And the first case is going to be presented by Dr. Arun Gopi, who's Director Cath Lab at Metromed International Cardiac Center, Kozhikode. Arun is a very versatile operator and a good friend. We keep bumping into each other. We look forward to your case, Arun. The stage is all yours.
So, anything else because this puzzle I'll try and see how I can optimize that.
Arun, your slides are not there.
Counselor trainer.
Yeah.
Will you be able to
can everybody else be mute? I think there is a noise coming.
Train all your other trainers.
At the moment, so we just have this active counselor.
Can everybody go mute so that we can listen?
Yeah, so am I audible? My slides are visible?
Yes, you're audible and slides are very well visible, Arun. You can start.
Yeah. So thanks, Veiva, for the opportunity. And it's like a privilege to be presenting in front of such a renowned expert like Chadda sir and A.B. Mehta sir. So as Chadda sir put the allude to the role of bed preparation, I'll be alluding to a case of LMCA trifurcation, where you understand that we are leading with fibrotic lesions and bed preparation is the key. So this is a story of a 45-year-old recently diagnosed of diabetes, non-ST elevation MI, recurrent rest angina, echo preserved LV function, had recurrent rest angina. You will see the angiogram in the next view. So he was having angina because of guide stenosis in the LMCA, was rightly advised bypass surgery. But unfortunately, because of his young age, patient and family was just not willing for surgery. They wanted to have a PCA done, and they were, despite being counseled by the heart team at multiple centers, they insisted on getting a PCA done. This was the angiogram. So you'll understand why he was counseled for a CABG, rightly so. It's a LMCA true trifurcation stenosis, left dominant system, Medina 1111. Significantly sized ramus. RCA is normal and non-dominant. Ramus originates within 3 centimeters of the carina. You have tight lesion in the LAD, ramus, and LCX, and the lesions extending more than 10 mm from the carina. So this is the still image of the trifurcation. Good size ramus, LCX dominant, tight lesion, LAD ramus, and LCX syntax score of 34. Our strategy, since he was not willing for surgery, was to have stents in LAD and LCX and a DEB in the ramus with a backup of a triple stenting strategy. And this is usually the strategy we do. We do a 2 stents in LED and L6 and do a depth to ramus. This is typically what we do for all kinds of these kinds of trifurcation. Since it was a complex PCI, we actually went ahead and did a hemodynamic assessments. The wedge was 15, PSS fluid pressure was 28, so there was no need for an upfront MCS. He was normal LV, normal blood pressure. So hemodynamics said that you don't need an upfront MCS. So we went ahead and did the procedure. Since it was trifurcation, instead of using 8 French guide, we thought of using a dual guide approach. So bifemoral axis, both sides we have 7 French guides, EBU 3.5 7 French guide. From the one guide we have wire in the LED, and from the other guide we have wire in LCX and ramus. So we do a eye imaging of each of the vessels. So first is the ramus. You can see the IVUS pullback of the ramus shows a very fibrotic plaque, some amount of very superficial calcium. Distal reference diameter is 2.7 in the ramus. The minimal lumen area is 1.5. From LCX pullback, again, you can see on the pullback, very fibrotic plaque. Distal reference diameter is 3.5. LMCA on the pullback is about 4.5. The plaque burden in the ostium of LCX is about 70%. You can see it's very fibrotic plaque. This is the pullback from the LAD. Again, a mixed plaque. So a bit of calcium, again, but predominantly fibrotic plaque. The LAD is about 3.5. The LMC again is 4.5, as we saw from the L6 pullback. So we have definitely fibrotic lesions in the trifurcation. And in any kind of these kind of PCIs, bed preparation is key. And we used Aperta, the novel scoring element, non-compliant balloon with triangle nitinol scoring microtomes, which has a nominal pressure of 14 and RBP of 24, which allows us to give high pressure blood preparation and has a very ultra low crossing profile, which is the reason why we thought of using this balloon for bed preparation. And our strategy is pre-dilatation with quarter size lower scoring balloon, that is quarter size lower Aperta, with one after that 1-to-1 non-compliant balloon at high pressure. So we did bed preparation with 2.75 2.5 non-compliant 2.5 scoring balloon in ramus, followed by 2.75 non-compliant balloon. LCX again was prepared with a 3O scoring balloon and 3.5. The same was done for LED. So, but after the bed preparation, you can see there's significant recoil in the ramus. Despite the aggressive bed preparation, we gave good amount of nitro. We found that the ramus had significant recoil, and so we thought of using a 3-stent strategy. So once we had decided on the strategy, subsequent procedure was as planned. So from one guide, we did a mini crush to LCX ramus bifurcation. We tackled the LCX ramus as a bifurcation, 2.75 38 in ramus and 3.5 24 in LM to LCX. Did all the steps of the mini crush, deployed the ramus 10 pullback, gave a flare for it, did the proximal side branch optimization, took the balloon out, took the wire out, checked for any dissection. After that, crushed the ramus with LM to LCX stent, did a pot in the LMCA, and then from the first guide, we from the same guide, we recrossed into ramus, and then opened up the stud towards the ramus, did a kissing balloon to, we did a kissing balloon 2.75 in ramus and 3.5 in LCX, completing of the mini crush in the LCX ramus. After finishing a mini crush in the LCX ramus, we did the second guide using a ping pong approach. We crossed across from the LMCA to LED, started preparing LED with a 3O scoring balloon and 3.5 non-compliant balloon. Prepared the LED. On the imaging, we know that the LED and LCX were equal sized. So we thought of culotte stenting in LED, LMCA and LCX. So we used a 3.5 28 in LED and 3.5 28 was deployed from LM to LED, and a pot was done in LMC with 4.5 balloon at 18 atmospheres. Now, once the pot was done from LM to LED stent, we take this first guide, pre-wire through the LMCA stent into the circ and ramus, and each of these struts were sequentially opened up. And then we do the most important step of the trifurcation, the triple kiss. So triple kiss was done with 3.5 in LED, 3.5 in circ, and 2.75 in ramus in multiple sequences. Each of these sequences done at 18 atmospheres, and finally simultaneous multiple times trussing done with at 12 atmospheres with 3.5 in LED, 3.5 in circ, and 2.75 in ramus. And final part of LMCA was done with 4.5 non-compliant balloon at 18 atmospheres. Only thing ensuring that since there are two guides, we should not ensure the stent in the LMCA ostium. And this is the final IVUS from LAD, well expanded. Ostial LAD MSA is 8.7. MSA of the LMCA is 13. Pullback from the IVAS showing an MSA of 6.1. Pullback from the LCX, MSA of 9.8. So we did a pullback systematically from each of the vessels. And this is the final angiogram. You can see the three stents, the stent boost image of three stents, 100 ml of contrast was used, 90 minutes was the procedure time. Patient was stable throughout the procedure. Patient is kept on ticagrelor and aspirin. We plan to keep this kind of strategy for 3 years. And then he's asymptomatic on follow-up. And this is the final angiographic outcome. So this is where we start off with image guided, finally having a good result on the trifurcation with post-PCA areas of 13 in LMCA, 9 in LAD, 9.8 in LCX, and 6.1 in Ramos. So this was a true LMCA trifurcation, which we required a triple stent strategy. We understand that once you have three stents, there's a lot of maze happening, a lot of maze on follow-up. The important thing is to have imaging guidance, adequate bed preparation, and trussing. So this was a complex trifurcation where we used three stents. We used actually a hybrid approach of mini crush to LCX Ramos and a QLO to LAD and LCX. The important thing was having two guides in which made the procedure easy. IVAS guidance throughout the procedure, pre-run on each of the three vessels and post-run on each of the three vessels. The most important thing to get adequate MSAs out on the image was to have adequate bed preparation done with a novel scoring element of aperta. And the proof of the pudding, as they would say, is on eating. So we had a check angio on this patient at 1 year follow-up. You can see pristinely clear results at the end of 1 year, because this is something which we don't prefer to do, having a lot of stent metal in this carina. But we did a check angio for him. He's asymptomatic at 1 year, and you can see the check angiogram. Everything looks pristinely clear and good. So probably the reason why these stent results are still holding on good at the end of 1 year is probably the adequate bed preparation from the scoring balloon and the image guidance and the trussing techniques that we use for this LMCA trifurcation. So I'll hold on with here, and I'll be happy to take on any questions on the case. Thank you.
Thank you, Arun. That was a nice trifurcation case done. I open the case for discussion. ABM sir is here, sir. Please welcome. And know at what stage you joined, sir. Arun showed a distal left main trifurcation lesion where he put 3 stents.
Yes. How old was the patient, DS?
45 years, sir.
Okay.
45
right.
years.
Right.
So he prepared the beds. He used 2 guides in a ping pong, using the ping pong technique, and did mini crush between ramus and circumflex, and then he did a culotte from the LAD left main. And then he finished with trissing simultaneous. He did sequential for each, then kissing in branches and repot, followed by a repot. And thereafter, he's done a 1 year follow-up, demonstrating patency of the stents, all done under imaging, sir.
Question is that what kind of recommendation does he have? Like when we do this kind of a case, we need the side branch entry for this. There are some stents which provide a large strut size and on the side, and at the same time a good expansibility of the strut. So what stent did you use, Gopi?
See, these were synergy stents, sir.
Say that again.
So these were synergy.
Boston Synergy stent, sir.
Boston Synergy stent. Yeah. Okay. With the situation, DS, you have particular choice or any stent?
Sir, I think most of the stents from the MNCs compare well to each other, and they all give you good cell openings. The only difference is Medtronic stents don't have links, so you will not face that problem of a link coming in between. And if you have proximal large calcified vessels, I prefer Megatron, because that gives you the largest cell size. Even Nagomi by Termo is a good stent with very nice cell openings to give you side branch access.
Also, I think a differential expansibility, such as I think if there is a gross disproportion between LAD and the left main, and there I think that has to be kept in mind too.
Yes, absolutely.
I think you're right. I think most of the new generations, but I have found Ultimaster capable of providing. That's the same thing as Nagomi.
Yes, sir. Nagomi.
Now is Nagomi.
number.
Yeah.
Correct. So
Very
that's
good case,
important.
Gopi. Good case.
Thank
So
you, sir. Thank you, sir.
anyone else, any comments? I can see
So, Gopi,
Saurabh.
that was, yeah. So, normally the 1 year follow-up was really good and the result was pristine, but normally these trifurcation stentings are associated with a very high restenosis rate. So, I assume that you'll keep the patient on ticagrelor or
Yes,
probably
yes,
lifelong.
for,
You know,
yes.
you'll probably be stopping it after a year or so. So, and
No,
what do you
ticagrelor.
think? What do you think is the role of using anticoagulants at a low dose, at a roxaban 2.5 BD when you're doing these kind of trifurcation stentings off-label? Because you're more concerned with stent thrombosis rather than restenosis. Restenosis can be dealt with, but stent thrombosis, the patient's not going to come to the hospital back. Right, that is one. And second is, do you think you'll keep the patient on inclisiran, a 45-year-old with trifurcation stenting? So you'll try to keep the LDS as low as possible, and what is the management strategies post stenting? And thirdly, yes, you must have used quite a few scoring balloons because you require different size scoring balloons for the rammers. The LCX and LD, probably you can use the same size. So I think it's quite an expensive proposition using different
Yeah.
size scoring balloons for.
So, yeah, so wonderful question, sir. I'll take each on one. So your antiplatelet strategy for us, the strategy was clear. 90 mg BD of ticagrelor for 1 year, followed by 60 mg BD of ticagrelor for next 3 years, along with aspirin 75 mg. No anticoagulants. With ticagrelor, adding anticoagulant, although gives dual pathway inhibition, risk of bleeding goes up. So I don't want to stop antiplatelet or any drug in view of a risk of bleeding. So I'm very comfortable with ticagrelor 90 mg BD 1 year, 60 mg BD for next 3 years, and aspirin 75. After that, I presume that I'll still stick to a single antiplatelet, which might be clopidogrel. Subsequent to your issue of lipid lowering agent, I would stick with a high dose of high intensity statins and estimate. If I am not able to get his LDL less than 55, I would add inclisiran or possibly Repatha if I'm not able to achieve the LDL targets of less than 55, and or preferably if even a target of 40 might be considered, although we don't have like so much of evidence to say about 40, but 55 would be my target.
No,
The
so
third
do you
question,
think? Yeah.
the third question you asked was about the number of scoring balloons. So one thing I found with Aperta is it gives you tremendous reuse. So we used 2 scoring balloons, 2.5 and 3. 3 balloon was used in LED and LCX, and 2.5 was used in the rammers. So we had just 2 scoring balloons used, and we tend to have good amount of reuse with Aperta. And since we are using 2 guides, we have good space through the guides to take these scoring balloons in.
And do you think you need to get a lipoprotein A levels done besides the LDL levels?
Yes.
Do you think lipoprotein A
Yes.
would be a good thing to get measured so that you can start the patient on inclisiran irrespective of the LDL levels? Because high dose statins and ezetimibe have been shown to be either neutral or increase lipoprotein A levels. And one of the other
Yes.
compounding factors in these young patients would be high lipoprotein A. So
Yes.
we
Yes.
practically young patients who undergo a bifurcation or a trifurcation stenting, we normally, irrespective of LDL levels, start these patients on inclisiran if they have a high lipoprotein A, because that's the only medical treatment that we can offer them, besides, of course, that we have stented them, so that they don't come back to us with ISR and other problems.
Agree on your point, sir. But this patient's LPA was normal. Since he had gone to 3 surgeons for this surgery, they had evaluated his LPA. LPA was normal, and there was surprisingly no family history of premature CAD or anything. So why aggressive CAD at 45 is still a dilemma, but we tend to see them.
All right. Any other co-panelists with any comments? I'll give a couple of my points in case.
DS.
Sir, I wanted to add a few things. Number one, Arun, you showed this case. I don't think there was any significant calcium from the IVUS runs, which I saw. That is one point which I wanted to bring. And two, since there are going to be a lot of young operators who have joined the webinar, I would bring one very important point to their attention is that in trifurcation lesions, please avoid 3 stents. You know what Saurabh was trying to tell? If you put too much of metal in the carina, stent thrombosis is going to be phenomenally high. So, I mean, 1 stent is better than 2 stents, 2 stents are better than 3 stents, and 3 stents are best avoided. You should try your best. The other thing where the use of cutting scoring balloons is concerned, since I move around and go to labs and I meet a lot of people, what I've seen is that people don't have patience when they use cutting scoring balloons, like a Partha or the other devices. If you inflate these balloons, you need to stay for at least 30 seconds because it scores very well only if you give a duration. So I always joke and tell the operators that inflating balloons in fibrotic lesions is a marathon race. It's not a relay race because people go to 2, 4, 6, 8, 10, 14 negative. I mean, it's like
No,
handing.
that doesn't work. No. Correct.
So,
You're right.
so one must stay at that pressure for high, and it preferably if you go to little higher pressures closer to the rated burst pressures, you'll get very good luminal gains. And this is even more important in the era of there is an epidemic of drug coated balloons these days. Anyone and everyone wants to put a drug coated balloon. So if you've not prepared bed well, it's going to be a problem. But you've been very meticulous. And Saurav's point of inclisiran, I don't identify with it. I mean, I'm not that aggressive because it's very expensive therapy. Everybody cannot afford. But in select patients, yes, we can give, especially those. I mean, there is an indication which is emerging of high lipoprotein A levels. But if that is not there and your lipids are well controlled, I think we can easily manage with statins.
Well,
So,
Dr. Chetty, your points are very well taken. I just add another 2 points. One is that I feel inclisiran is not expensive. The reason being is that they give one injection free with one injection that you buy. So it's so, and if you look at the cost, if the patient comes back with an ISR, the cost that he's going to spend in getting a retreatment is way beyond the cost that he would spend on inclisiran. That is one.
I absolutely agree with you, Saurabh.
And
But
another important point is that you already highlighted that you need to keep the balloon inflated for some time. Another thing that I have observed in the practice is that you need to give multiple inflations. That also helps because it changes the compliance of the vessel. So it's not that you inflate the balloon once and let it go. Keep inflating at the same point again and again, and that changes the compliance of the vessel over a period of time and gives you better MSAs once you stent them.
absolutely agree. Absolutely agree. Absolutely agree. So, are there any other points from any other co-panelists? ABM sir, would you like to add anything?
No, I was just trying to tell that, see, obviously now that at the end of 1 year, when his angiography shows a sustained benefits, whatever he did has proved to be right.
Absolutely.
And therefore, our
Definitely
questions and
blessed.
our questions are hypothetical.
Exactly.
Whether what strategy we use would have worked or not, but whatever strategy he used, it worked. It is shown for 1 year. So I
Absolutely.
think whatever he did has paid off a good dividend. So I would be inclined to believe that what he did was absolutely appropriate.
Mm.
Number two, I
Absolutely.
want to say, you're right, Devinder, that drug balloon, I'm still sitting on the fence because I had couple of not very pleasant experiences with the drug balloon. They came back with the symptoms again, and I found that the plaque has come back. So it's probably the hype is a little bit too much, I feel, and I'm sitting on the fence. I'm going to watch. And if that if it proves that over a period of time it works, then this case is very simple. The REMS is excluded automatically if you do. And recently I had gone to Japan and there was a guy, I forget his name, but he did the sarcostium and used 2.15 burr. Now I've never used in my life such a big burr.
All right.
And it's not available only. Devendra, it's not
Sir,
even available
not
to us.
available. Sir.
Yeah, he did, and I think it's a pristine result. I don't know how long that benefit would sustain, but I think it is under observation, under study, and I'm watching it. Let's
Wonderful.
proceed now.
All right, sir. Okay, sir.
Thank
We'll go on to the next speaker, who's
thank
going to
you, sir.
be Dr. Sanjeev Gera. He's from Fortis, Noida. I've had the opportunity of being in his lab. Wonderful person. Sanjeev, we look forward to your case.
Hi,
Please
sir.
load
Good
your
evening.
slides and
Good evening, everyone. Let me just share my slides. Where are the slides?
Hello,
Yeah, just sharing the slides.
I'm at home.
Yes, right.
What's it? Just selecting the screen. Okay.
So this was my, I hope my slides are visible.
Yes, your slides are visible and you're audible, Sanjeev.
So basically the agenda is optimal plaque modification. So I will just share few of the cases done with Aperta, and Aperta made a huge difference to my bed preparation, the lesion preparation, which is actually very crucial. We all know that stent under expansion is correlated with stent failure and bad outcomes. Lesion modification is very important. Plaque modification tools, we have many on our shelves. Especially we have different techniques to modify calcium, like balloon-based strategies when we have non-compliant balloons, scoring balloons, cutting balloons, and then we have ablative techniques or atherectomy techniques. So this chart actually compares scoring with cutting balloon, just a simple chart to give a simple idea that what advantages we have with scoring balloon. There is lesser chances of perforation, lesser chances of the blades getting stuck into dense calcium. Better for fibrocalcified lesion, aperta balloon or any scoring balloon. They have got higher RBP with better crossing profile than cutting balloon because they just snap the plaque as compared to the cutting balloon, which make deeper cuts in the plaque. So this is case one, patient profile, 55 years male, diabetic hypertensive, presented to us with unstable angina. CAG showed triple vessel disease, almost normal LV, severe calcified DVD. RC was a bit 70-80% lesion. So he refused for cabbage. So we actually planned one complex PCI with calcium modification. This is the angiogram. You can see in plain cine, even in the fluoro, the calcium is quite visible. So we actually do imaging, try to do imaging in most of the cases, but because of the cost issues, we couldn't do imaging in this case. But definitely, it is quite visible that there is a lot of calcium in both LAD and circumflex, and it seems that circumflex has got a calcium nodule also. So this is how we did, and we use some ETO IVS catheter just to have an idea of the calcium. So the LED you can see densely calcified, and circumflex also circumferential calcium with nodule. So we first started doing rota to LED with 1.5 bar, and then we after doing rota we gained some lumen after ablation. Then we went ahead with Aperta 3 by 13. So we call it rota score rather than rota cut. Now we avoid actually cutting balloon after rota ablation because we have encountered two or three perforation cases after using cutting balloon after rota ablation. But this gives an actually adequate lumen gain. You can see because we can actually go up to higher pressures, up to RBP without any fear of getting perforation because the expansion is not that much. It actually puts more pressure rather than expansion. So this was 3 by 13 rota scoring balloon aperta. And then you can see the lumen gain. Then we put a test here, 3 by 33, and stent was very well expanded. And this is the final result in the LED. Now we thought of intervening LCX. It was a calcium nodule. Somehow, actually, our wire got stuck in the balloon, the rota wire. So we could not actually use that wire. And because of cost issues, then we thought, let's go ahead with balloon-based techniques. And there could be an issue of rota wire bias also. So we initially took this aperta balloon 2.7513 and in the crossing profile you can see that it went into the lesion very easily, and we first inflated to 18 atmospheric pressure, but the lesion was not giving up, and you can see there was still some dog burning, some lesion left, and then we went up to 22 atmospheres, and you can see now it gives away, and the balloon is very well expanded. Then we modified it with some high pressure balloons and then deployed test 3.5 20, and you can see the very well expanded stand. So the result was actually quite optimal. So that is how this aperta balloon made a difference to this PCI. This is case 2. You can see ACS, instant thrombosis, instant restenosis, and this is when after passing the wire. So there was a lot of thrombus also. We sucked out the thrombus, then we used aperta balloon because there was a fibrocalcific lesion 2.513 from distal LED to mid LED, and then we prepared the bed because there was fibrotic calcified lesion. We never use non-compliant or semi-compliant balloons because there is a risk of dissection, and the disease, the LED is totally diffusely diseased, and there is no safe stand landing zone. So better to use aperta balloon where dissection chances are very less, and the balloon expanded very well and usually gave away. Then we used 3x13 for instant, same aperta balloon. This is post aperta. So we plan to put DCB 2.530 to the mid to distal LED, and we we basically use two DCBs here, 3x13 in for ISR, and this is the final shoot. You see the optimal actually result after using aperta and DC. So that is how actually aperta made a difference. And this is case 3. 43 years old lady came to us with acute coronary syndrome. OM, you can see it is totally occluded with thrombus, 7 days pain. And there was late, this was late presentation. And you see on my right side, when we used 2.5 18 non-compliant balloon. So first we dilated the OM, and then you see on my left side the balloon, the non-compliant balloon 2.5 15. It will just it slips up. It is not holding. The lesion is not holding because of too much of fibrosis and calcium. And then there was a this was basically bifurcation lesion. Then we put second wire in circumflex. We used 2.5 15 same non-compliant balloon initially, not very higher pressures, just to prevent dissection. But we thought of then going ahead with aperta. The aperta 2.75 13 was used for circumflex and OM, and there was no slippage, and the lesion actually gave away. You see here this, and this is circumflex bed preparation. So because she was young, we thought of doing a hybrid strategy to this lesion, stent to OM with DCB to circumflex. You see, there was very less recoil with aperta when we used aperta balloon, especially in the circumflex lesion. Then we deployed DCB 2.75 30 to the circumflex, and then we prepared more OM lesion, and then we deployed one DES and DCB to the circumflex. The lesion was very well optimal, and it was acceptable lesion. This is the final shoot. So key takeaways from these cases are that final PC outcomes actually depend on selection of plaque modification devices, and we very often have around 60 to 70% of patients, they have too much of fibrotic lesion because of diabetes, CKD, and aging especially. And we need to have different types of strategies on our shelves. Aperta is actually 3 nylon element, and it's basically non-compliant balloon, and it gives us precise circumferential scoring or snapping the plaque, ensuring uniform lesion preparation. And it is designed to modify resistant fibrotic plaques with very less chances of perforation or dissection because of controlled force application, and as compared to cutting balloons. Imaging is definitely should always be done in most of the cases so as to assess the plaque morphology, to size your balloon, and to plan your stent strategy. Thanks a lot.
Thank you, Sanjeev. Those were very nice cases. So I open your cases for discussion. ABM sir and other co-panelists, I can see Girish has also joined now.
Okay, very good. Devendra,
Sir.
that you are going to deal with a calcified lesion, that knowledge comes to you when you put your foot on the screening machine for the first time, because it is not a usual practice, because the only non-invasive method that can tell you the calcium much more sensitively than the angiography is a CT angio. And we do not have a routine practice of doing CT angio in every patient before we take him onto the table. So the first evidence that you are going to deal with a difficult situation or a demanding situation with calcium load, that information comes to you when you do the screening. Now, there are people who have gone and doctored and they say, okay, sir, all this calcium is it's a distant, it is deep calcium, not superficial. It will not matter. No, 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 no. It's not possible to be able to judge that way. It is, I think, trying to make believe or a compromise. I think that's a wishful thinking largely. That doesn't happen. Number one. But you may have some idea about the degree of calcification. For example, if you say that the calcium is barely visible and is scattered, then it's a mild. The moderate calcium is one which you can see only when the fluoro is mobile. The screening is moving and it's on, and the third one, the heavy calcium, is one which is in the static film, and not only that, but is it like a tram track on both sides. That I think is going to require a plaque modification strategy, and in all probability those people who do not have an imaging facility or not inclined to, you and I, we very well know, DS, that the imaging has penetration is of 8 to 10% at the most in our country. So therefore sometimes, and the calcification is as high as 30% of the patient have a calcification. So I think very often, I think that the procedures are carried out without imaging device, and then I have to talk one or two words about how do you handle such cases. Now, what I just now a presentation with, I think, where I heard that pressure of 15, 20, 22. Now, if you have done a rotablation with 1.5 bar, and if I find at 12 atmosphere I still have a dumbbelling or the waist is not giving up, my strategy is to upsize the bar 1.75, because and then what happens is that you go to 12, it's still dumbbelling after rota. You go to 14 atmosphere, it's still dumbbelling after rota. And then once in a while, that I think is a perfect strategy, perfect I should say, a trap to fall into a perforation or an ugly dissection. So I think one should be prepared that if the lesion modification at 14, the good lesion modification with a atherectomy should be able to give in a good balloon expansion at 12 to 14 atmosphere. And it's a good strategy, at least from my side, to believe me, that you upsize it, but don't go too high. And believe me, you go to, I think it's probably the calcium is probably not cut very well. There are not enough cuts made. And 1.75. And you, in fact, DS, when after the first burying, I make an injection and see how much have I gained, how much have I gained in the critical area of the lesion. And then if I find that that's a problem, then I think sometimes what I've done is I've not removed the rota wire. It stays there. And by the side of this, my regular wire is there, and I do a balloon expansion. Maybe rota is an additional poor man's cutting balloon, and is not intended for that purpose. But then subsequently, if I want to add up and step up the rota, my wire is already there. There's our truth. One more thing I want to say, that after rota, very high pressure is definitely to be taken with utmost care and utmost reservations. That I think should be avoided. Majority of the perforation that I've faced in my complex cases with rota have been with associated high pressure balloon dilatation. One more thing is balloon slipping strategy. And one for you, DS, to you, because you are a thinking cardiologist. So I'm going to put one question to you also right now.
Sure.
And that may be useful to all of us. The balloon sleeping, I think what I do is that wipe out all the glistening or lubricating material from that several times, or I can even expand the balloon in the guide catheter and deflate again, and that is crimped balloon, then it goes, I think it slips much less likely. Of course, once in a while you might not be able to cross because you've lost the profile. So there is a downside to it also. Now, question to you is this. You see, a 4 millimeter balloon at 1 atmosphere will have a wall tension X. And according to the Laplace's law, the wall tension is equal to pressure into radius. Your radius in 4 millimeter balloon is very profiting radius. The pressure to generate the same wall tension, which I think 2.5 balloon require the pressure of 6 or 8, can be obtained by 4 balloon with 1 or 2 atmospheric pressure. Wall tension is identical in both cases, or you can achieve an identical wall tension by altering the pressure in a smaller balloon or reducing the pressure in the bigger balloon. Both the balloons have to be in contact, needless to say, they have to be contact in the vessel wall. Without that, it has no meaning. Now, which is better, DS?
Smaller balloon, of course, is better, sir.
Why do you say that?
So I will tell you the reason for that is that there is a tendency with a larger balloon to go up, and it's the dumpling which will fold the intima and produce perforations. So one has to be very careful with that. So that's what I have experienced in practice while doing peripheral interventions. In the iliacs or in these vessels, I've had perforations when the lesion looked very simple, and with a larger balloon in aortic or in peripheral intervention, you don't go beyond 6 atmospheres. Sir. But very rarely you will find a cardiologist who will hold the balloon. Only Dr. A.B. Mehta can hold the balloon at 2 or 3 atmospheres. Reflexly, everybody will go to 4, 6, 8. And
Yeah, go ahead.
that will cause severe dumbling with the infolding of the intima with perforation. That's what I think.
Okay, but I'll tell you the observations. Much before, tell me one thing. Did you become an interventional cardiologist after the stent era or before the stent era?
No, after the stent era, sir.
Okay, and I've been in both before and after. So, so I'll tell you one observation. At that time, I think Nicholas Reifhardt, David Oth, and bookbinder Morris Bookbinder, we were the people who were doing angioplasty with rotablation, only a balloon dilatation, and there we had found that if you take a larger balloon at a lower pressure, come down again, do it again in several balloon dilatation, gradually produced a better result. And probably in those days, it was credited with a less restenosis. Now that problem. But in any case, one thing is I'm really certain about DS, and that is don't go too high pressure, but don't hesitate to upgrade your burr.
So the principle which you said is very well applied to avoid balloon slippage. What is recommended is that you go to 1, 2, and go up very slowly so that it holds.
Absolutely
And then
right.
it'll hold at the site of the lesion, and then you can go gradually. Balloon slips only if there is a differential inflation in the balloon, either proximal or distal, and it will move in the either direction. Whichever side inflates more will push it or pull it towards the
Yes,
opposite
right.
side.
What very true. I think what we used to call as a watermelon seed effect.
Correct. So same.
Yes, and that happens truly. You are right. If watermelon, if you hold the whole watermelon and it will not slip, but if you hold it at the tip and you press it, it will slip out naturally. So I think your point is well taken. And sometimes if you have it's like as I said, your rota wire and your regular wire are together because you have kept the rota wire purposely there just in case if you have to upgrade the burr, then it will not slip. Yeah. Okay.
So we'll ask the other panelists now. I can see Dr. Prashant, Dr. Girish, Dr. Sahu. They've all been very quiet. So we invite comments from them regarding the case and their experiences in brief so that then we go to the third case.
Yeah. Thank you. I think Dr. Cheda said it was wonderful. I think if cost is not a factor, I think Aperta or Wolverine will become the default balloons to treat a lesion. You don't have to uniformly expand the whole, the lesion. If you just have precision incisions or plaque modifications along with the balloon, would suffice. But again, because the cost, you need to be judicious. And when you look between arteriotome blade related versus wire related plaque modification tools. I think they both do wonderful job. And my experience has been tremendous on blade based, I mean, acetone based, but I have definitely used some of the Aperta too. I think if it is fibrocalcific, which is very superficial, I think these do great job. But if you really have more than 180-degree or a 280-degree calcium, more than 0.5 millimeter thickness, I think they may not be the primary tool of plaque modification.
Dr. Prashant and Dr. Sahu, any comments?
Yeah, Dr. Chadda, I would like to know from your experience, what is the maximum pressures you go with Aperta balloon? And did you have had any perforations anytime in your practice?
Perfect. So I very often go up to 2024 while preparing. Now, I will tell you, I have not had any perforations. Now, if I do a head-to-head comparison between Aperta and, say, Wolverine or the angiosculpt, the Aperta has a virtue of not going beyond maybe 5% of the size which is specified. I mean, a 3 balloon will rarely go beyond 3.1, 3.2. Whereas if you take a Wolverine to about 18 or 20 atmosphere, a 3 becomes 3.5. That doesn't happen. So that is one virtue which Aperta has. And these nylon stripes they are embedded in the balloon fabric itself. So it doesn't go, the diameter does not, there is no differential expansion at higher pressures. What we see in probably the OP and NC balloons, the double layered balloons, which also in the compliance charts don't go up to very big diameters at higher pressures. So yes, I have not had any perforation. Then I routinely go up to the nominal. And if I see there is some dumbling or this thing, I have absolutely no fear in taking them to higher pressures, at least to the RBP. That, of course, we do gradually in checking in orthogonal planes.
Perfect.
I'd like to make a comment, and I think these balloons are pretty safe to use, but then one has to use imaging when one is sizing these balloons. I don't understand how can someone use these high pressure scoring or cutting balloons without using imaging, because that is how you size them and that is how you decide what pressures you go up to. So imaging is a prerequisite when you're using these balloons, because first they will tell you how fibrocalcific the lesion is, where you need to concentrate on, what are the points that you need to concentrate on, and secondly, it tells you what pressures you need to go up to and what size balloon you need to use. So without imaging, I think it's not possible to do justice using these expensive balloons.
Any other point? Anyone? Dr. Sahu's been very quiet. All right. So
and my experience is I've seen these balloons work exceptionally well, even in 360-degree arcs of calcium. And I've had a case yesterday. It was a balloon crossable, severely calcified RCA with 360-degree arc of calcium all through, an 83-year-old gentleman. And I was not comfortable doing a rotor all through with its consequences of slow flow, no flow. And I used two Apertas, 3.5 to 4, which I was able to cross after pre-dilatation with a 2.5 NC. And I got MSAs in the RC as high as 8 to 10 in a vessel which had 360 degrees arc of calcium extending for a distance of 8 to 10 mm. So
wonderful.
These balloons do work. They do wonders.
I quite agree with you, Saurabh, but the confounding factor here is, thickness of the calcium plate. If you have a very thick calcium plate, none of the balloons are going to work. You will need either IVL or you need to reduce the thickness of the plate either with orbital or rotational atherectomy. Then only the cracks will come because they have their own limitations. So, I mean, in medical science, 1 + 1 is not 2.
No.
And larger the arc of calcium, more are the chances of it fracturing. That is what Fein et al. Showed in their study, that if the arc of the calcium is more than 220 degrees, it gives a good grip for the balloon to open up and crack the calcific plate. And in their study, they found that cutting scoring balloons work best if the thickness is less than 600 micron. So any thickness beyond that, you need some additional tool.
Yeah.
So, but wonderful. I mean, your experience has been very good. And I mean, the key is what you mentioned. If you have the provision and the patient can support it, the sizing is important, which is a very, very important point which you brought out. Very, very important point.
And also depends upon the size of the artery. If the size of the artery is 3.5, then probably you can get away with a balloon. If it is a smaller size artery, then you have the difficulty with a only balloon strategy. Then probably you have to use a rota, because if the artery is more than 3.5, probably it would work as well.
Yeah, Rutvik, your slides are visible. I hope you are not impatient. We've not called you. We've had a long discussion, but we are very excited to go through your case. Please go ahead and present.
Yes. Am I audible?
Yes, you're audible, Rutvik.
Fine. So I think a wonderful discussion, and continuing on the same topic as Sir you and Mehta sir pointed out. Just the basic that the prevalence of calcium is increasing. Almost most of the trial have suggested, and we as interventionists see almost 25 to 30% of the cases of such complex coronary interventions in day-to-day practice. Even in ACS also, we had the same scenario. We have various tools, and that we have already discussed. Algorithms which are available, but there lies some frugality or a sense of austerity in managing such complex lesion. Especially the sir pointed out mild to moderate calcium, we still go by angiographic patient. So by what I mean to say that, yeah, we know that certain lesion will definitely need certain tool. So uncrossable lesion, calcific lesions with clot, nodular lesion, we have clear-cut idea. We have IBUS, OCT indications very clear. But as you pointed out, the fibrotic lesions and mildly looking calcific lesions, when we take certain patients, especially at the ostium, we always face challenges. There, the guidelines and the
Rutvik, sorry to interrupt. If you can switch off your video, your network is slow and your presentation is getting interrupted.
I share my experiences. So, a 61-year-old hypertensive male ACS presented. Importantly, had a radiotherapy been taken for a CA buccal mucosa. Hypothyroid ejection fraction was 45%, and this was his angiogram. If you look at its angio, it almost distal LMCA bifurcation lesion pattern. LED looks quite fibrotic lesion, haziness in the ostium, and it looks a fibrotic lesion. Ectatic segment in the middle part of the LED is same as in the middle part of the circ. So we discuss and then the plan the intervention of the next day. On IVUS imaging, this was the ectatic segment. Vessel was very large at this point. The mid part has a fibrotic lesion predominantly. The minimal lumen area at the tightest portion was almost 2.01, and the lesion was the LMCA was large, almost 5.6 mm. LED also had the same features. Fibrotic lesions in the proximal part, LMCA almost 5.6, and like a calcific arch of 360-degree, even the fibrotic lesion was also having the same 360-degree pattern. We chose the balloon strategy to put cuts and create a lumen so that the stents will get expanded. So first we treated the sarcostium by Aperta 4 by 13, then the LED was taken. And as you rightly pointed out, it has to be a slow. First 4 atmospheric inflation has to be slow. Then you gradually grow to almost 14, 16. Here we have so based on the lumen size, generally the selection wise, there is always a confusion. So I think you will give us more idea on as far as the sizing is concerned. But what I follow in my cath lab is I generally measure the lumen size and go to quarter of size. So this vessel was almost 4.5. So I chose 4 by 13. Post I had a good result. So this was a sarcostia, and I had a cuts present. The lumen gain was almost 50%. So that was a reasonable and satisfied result. So that I felt that I'll go ahead with the stenting. So the cuts were quite obvious, noted. Same way in the LAD also, the cuts noted. Good bed preparation, which was there with the aperta. The lesion looks quite open. It was the mini crush. I took 4/12. In the circ, 4/20 LMC to LAD. Properly cast prot was done. Recrossing was done. Kissing balloon and the final prot. And then the report was done. The sizes we have at the circ ostia was almost 9.26 at the ostium. Good symmetrical. You can still see there are a lot of fibrotic tissue at the behind the stent, but I felt that it was a reasonable expansion. There was no under expansion which was present. LMC was almost 20. And patient, I did this case almost 4 months back. The patient is doing fine. I had a second case, which is 69 years male, hyperthyroid, hypertensive, inferior wall MI, had a pulmonary edema, medically managed and referred for the management. He had anterior wall MI in 2050. This was his LAD. And as I mentioned, when you have a tram-track calcium being present, sometimes our job becomes very easy because we know what to do in such kind of lesion. We have very well defined strategies and algorithms which were available. So LAD lesion was calcific, but I was then sure that therapy. So RCA lesion was fibrotic. The calcium was not visible. Extensive, so probably it could be a mild, maybe a moderate calcium. Decided to take the RCA first. So RCA, the calcium at this juncture was almost, at this point was almost 180 degree, not a severe calcium, more of a fibrotic part in the rest of the arm. A fibro calcific lesion, again the arc was not complete, more of a fibrous tissue. The proximal part of the lesion, again, not arc is not complete, more of a fibrous lesion. Minimal lumen area of 1.05 at the tightest portion. The distal landing and the proximal landing was almost 4.5. Balloon did reasonably 14 to 16 atmospheric pressure dilate, and I image again was not happy. Then scoring balloon was taken 4/13. Again 14 to 16 pressure dilatation was done. Whole of the lesion was dilated. So post NC, I had a lesion, but post scoring balloon, there were good cuts which were clearly visible at the whole lesion, which I saw on the canvas. So proximal part also, there were good cuts, good lumen areas which were achieved. So stented 4/38, and then the NC balloon of 4/12, which was taken. 14 to 16 atmospheric pressure dilatation was done. But there was still some under expansion which was noted. Exit point. Stent was 10.8, proximal stent MSA was 11.2. Still, at this lesion, I found that MSAs were not good, 6.68. I rechecked. This was the lesion initially. I used pressure OPN balloon and then achieved a final size of almost 10. Proximally and distally, the MSAs were quite good. Again, this was not a big task. It was a balloon uncrossable lesion, did rota, dilatation, stenting, and came out. So what I conclude is calcific lesions are the toughest lesion. we have plans, we have imaging, we have algorithms, and sometimes a lot of discussion and advices from the expert has made our job very easy. But the fibrotic lesion we tend to underestimate, and that brings or invite more complications. IVL, as we all discuss, is an invaluable tool, and it should be used whenever we are using some aggressive balloon strategy. And post scoring balloon cuts on IVUS, they generally guarantee higher NSS. Thank you, sir.
Thank you, Rutvik. I open your case for discussion. Mehta sir, your comments.
Yeah. These were the cases of a very fibrotic lesion, and calcification was comparatively less. Now, this is a teaching seminar, DS.
Sir.
So therefore, I'm trying to say that which you might once in a while come across a lesion where nothing passes except your wire. Nothing passes. Now, under this situation, if you can't use a cutting balloon, you can't use a scoring balloon, you can't use IVL, and all those things are very difficult, and you are really stuck. Under these circumstances, it's my plea that since we are indulging into a more and more complex interventional procedures, I think we should be very well versed in atherectomy also. Now, in a situation where the wire has passed and nothing else passes, surely you can use and wedge the microcatheter as much as you can, and then change confidently and change it to rotawire. And once the rotawire is done, I think, please believe me, your battle is won. Because once you do rota, then everything else becomes simpler. So therefore, I think in my experience all over, wherever I've gone to Proctor, and probably maybe you also share the same experience, that people do have a little reluctance to use atherectomies. And I think one should eliminate that. And this, I think, is my point. And therefore, there have been people who think that IVL is a substitute for a rotablation. No, it's a complementary. It's not substitute. For example, deep plaques cannot be removed by rotablation, but IVL can influence the deep plaques also, deep calcium, what I mean to say. Right, DS? What do you have to say?
Yes, absolutely, sir. Absolutely agree with you, sir.
Yeah.
Balloon uncrossable lesions, I think rota is irreplaceable, the only front cutting device. And if you have
But it's still to come.
Yes.
Yeah.
So it's absolutely irreplaceable. And if you have nodules, then orbital is the only bulking tool you have. And if you have deep calcium, then IVL is kind of irreplaceable because that's the only tool which works in the deep calcium. Correct. I can see Dr. Barua in the panel. Dr. Barua, your comments or your experience since you've just joined. So.
Yeah. I'm sorry. Actually, I was delayed in the hospital.
Rutvik, please give up your screen, please.
Stop sharing the screen.
Actually, what Dr. Asin Mehta has told is, I think we all know that, and he's very experienced in these issues. So we know that if nothing goes, exchange to rota, and everything will be very simple. That we all of us know that. Only here, question comes, and you need to have some experience and kind of little familiar with the rota. And always the rota, there will be some inertia. We don't start. But if once you start, I think your life will be very simple in a calcified lesion. That is well established and a very good procedure. That's why I feel all youngsters should be kind of quite familiar with this rotablation, rotational atherectomy, because this is sometimes it save time, save a lot of other devices, and your results also will be very good. And most of the times we know that our coronaries are a little smallish and heavy calcification, intimal calcification are quite high. So in this case, I think rotablation is very, very good device. And after rota, I think many a time we can kind of manage either the openness balloon or maybe cutting balloon. Most of the cases can be managed with that.
Yeah. Very good. Very nice.
Dr. Girish, any comments?
Fantastically displayed. Most lesions treated with just wired balloon, and I think we all agree these are going to differentially exert pressures on those points and give you better expansions, and where you don't have imaging or ablative devices. I think these can solve most problems. But again, going at 14 and 16, 18 atmospheres, and if you still have a dot boning, then you must not go so high that you cause a dissection or hematoma. Then you can't use another ablative device. Then you will have to just wait for an IVR. So always do at low atmospheres the entire length and see whether it's yielding, and then see whether you should stop and move to another strategy or try and get best out of the balloons. Thank you.
All right. All right. Thank you. Thank you, Girish. And we go on to the last talk of the evening. I'll invite Dr. Arvind Kumar from Kaveri Hospital, Trichy, to share the screen and present his case. Yes, we can see your slides, Arvind. Can't hear you as yet. Hello? Arvind, are you there?
Am I audible?
Now you're audible. Now you're audible. Please go ahead. Please go ahead. You're on mute, Arvind. You have to unmute yourself. Please unmute yourself. You're on mute, Arvind.
Okay. Now am I audible?
Yes, you're audible. Now don't mute yourself. You're audible.
Oh, sorry. Thanks for the opportunity, sir. This is a 63-year-old gentleman. He lives in Singapore. He was on a pilgrimage tour to India. He's a basically Indian. I don't have any history regarding his past status. Only the verbal status of 3 ACS in the past with stents he had for the ACS. And the last 1 week he had hyperangina class 2, and the last 1 day he had rest pain. Hemodynamically stable at the time of admission, borderline renal function. So this is the angiogram of that gentleman. Okay. It was a acute coronary syndrome, and there was a proximal, it was almost the whole length of the stent was, length of the RCA was stented, and I could see the proximal part of the RCA is occluded. And I pre-dilated the whole lesion with a 2.5, and later on with 3 NC balloon. And from there on, I could understand the whole lesion was balloon, whatever we are discussing, the balloon, watermelon seeding, and it was not sticking on. So I knew that there was a lot of ISR, fibrous material is there, and it is not anchoring, and the balloon dilatation was difficult. So I went ahead with the OCT. The OCT clearly gave me a lot of insights of what I am doing. So it was a neointimal hyperplasia and neointimal atherosclerosis was seen in both across the RCA. The entire segment had the lesion. The proximal diameters were very small, and the recurrent ISR can be able to see multiple stents also there in the proximal ISR. So possibly they would have done the procedure without imaging. That's what I had a feeling, and this led to multiple stents there over there. So this is what the OCT showed me neointimal hyperplasia in certain areas and neointimal atherosclerosis in certain areas, and I could visualize at least 3 sets of struts. It was some side, the innermost layer was underexpanded. Possibly that could be the reason for recurrent ISR in this patient. Multiple layers of stent seen. So now I decided, having known that there is multiple stents over there, and I should not keep adding stents from my side also. And the whole length of my RCA was diseased and stented, and I have to open up the coronary. At the same time, I have to get the good results. So I guess once I knew that the approximate size of the stent, so I went again and dilating with preparing the stent vessel with a scoring balloon aperta. the distal one was dilated with a 2.75 13 millimeter. As we are in the past, we are talking about the time duration of. Usually, I tend to do it for 30 to 45 seconds unless there is an ischemic decompromise. So I tend to give it for a longer time. Then once it was there, then approximately I ascended up to 3.5 13 millimeter and tried to clear both the neointimal hyperplasia and the atherosclerosis. So my at all point of time, my intention was not to have another stent. So my vessel preparation must be much adequate. So again, I pre-dilated, kept on pre-dilating multiple times. Took out the balloon again. I possibly rotated and I had tried to cut it and score it in another direction, so that I can get multiple opening and creating ripples in the inner part of the intima and clearing the pathway for more things. So pre-dilated again and again, and then another set of OCT was run. So now I achieved much more optimal luminal gain. Plan to do more and more post dilatation after seeing that I was cleared it partially, but not good enough for deploying my drug coated balloon. So again, I thought my work is not done completely. So again, I had some understanding of what balloon to use and how much to go. So this time I post dilated again with a larger balloon, the same 3.5 the aperture balloon, but I gave it up to 20 atmospheres for 30 seconds each, and the proximal part and 2.75 30 seconds, 30 seconds for 20 atmospheres, so that I gained lot of lumen. So this is the prior to the second this thing post preparation vessel. There was sort of lumen gain, but it was not satisfactory, and went ahead with another pre-dilatation. This time for a longer duration and at a higher atmosphere. I took aperta with varying lengths from 2.75 to 3.5 ascending up. Then finally, I knew that I was much more comfortable. So I took a drug-coated balloon, the distally 2.75 to 20 millimeter, and I usually tend to give it for 45 to 60 seconds. And proximally, I did it with 3.5 40 millimeter, where almost 45 to 60 seconds was given, and optimal after all, the final check showed much more satisfactory results, even though the distal vessel was not flowing great. I had done the job without doing any another additional stent, and the final OCT picture I could not get. I could get that the struts, whatever the separated struts were, I could see that all were almost uniform. It was compressed into one, and I could get a lot of lumen size. And finally, the RCA at approximately it was 9.8 area was there, and I was much more happy to have it. But the distal was disappointingly diseased, and ultimately I gave him our best medical management, and he flew back to Singapore. And this happened a couple of months back, and he called me back saying that he is much more comfortable and no angina. So for me, that preparation of the lesion in ISR is very important. Knowing the pathophysiology is also very, very important. And because there is no significant calcium to handle at this point, I use scoring balloon, and appropriate size was guided by the OCT, and optimal size approximation of stent was done. And finally, I could get the drug-coated balloon, and I had a good result, and patient went home happily. Thank you very much for hearing. I'm happy to discuss something.
Thank you, Dr. Arvind Kumar. That was a nice ISR case. I open the case for discussion. I invite comments from Dr. Mehta, followed by the other co-panelists.
I think such kind of cases, Arvind, they are very sticky. And I would not be surprised that in 6 to 8 months of time, the patient comes with restenosis again. And especially I've seen these things of happening. Now, what happens is that the limiting factor is what is the quality of the previous stent? Is it the one which is expandable? Is it the one which can make it bigger? If there are limitations in that, then I think we are seriously handicapped. And no matter what you do, the pre-existing stent will not allow it to get expanded to your desired level. And I think you made a good attempt. I think the whole artery was completely studded with restenotic material, and therefore those kinds of cases, I mean, I think I'm not saying that one should not do on the anticipation that it will not work out. No, no, no. We always give a trial, and you gave a good trial, and I think the end result was reasonably satisfactory. But I think those kinds of cases are governed by the unfavorable pathology, and they do keep on giving. They are pain in the neck. That's my comment.
Perfect. Dr. Girish, Dr. Barua, Dr. Prashant, Dr. Saurav.
Yeah, I think this is a great case and very difficult case about Dr. Arvind Kumar done is a great job. Because as Dr. Mehta has told that we need to know about the stent, what is the stent use, what is the expandable limit of that particular stent. Because whatever you do, if you try to expand the stent, suppose that stent was not adequately sized, so obviously it may not expand. However, you have done a great job. Maybe I would have done another thing, probably because you have an open NC balloon. You need a very high pressure in this kind of situation. So open NC balloon sometimes is useful because already you have done a cutting balloon or scoring balloon aperta use. So it will not be difficult to there should not be Maloney effect and all. NC balloon probably 1:1 in this kind of situation. Probably we can go to high pressure. So that would have given maybe a little bit of more kind of this area of the particular area, especially distally, which was didn't expand that much. And I think beyond that, probably what you've done, you're a great job, and hopefully he'll do well. Thank you very much.
Girish, a pointed question to you. What is the protocol which you use in an ISR patient? I mean, bed preparation protocol.
Yeah, I think the first would be an imaging. Absolutely. Without imaging, I would not know the mechanism of stent failure, whether it's underexpanded or is it the new intimal hyperplasia drug has not done its job. Next, once I understand, I also look at the quality of the plaque, whether it's a soft plaque, it's a fibrotic or new atherosclerosis, or is it a calcified plaque? And then look at the content of the plaque. Is it how much is the inside of the stent and how much is beyond it? I think image will tell me very clearly. And very often I have found in an ISR that it's an undersized stent. I think take the imaging way beyond the ISR segments into healthy segments of the distal vessel or the very proximal vessels to expand it to match one of them. And I would use initially a cutting balloon just to get as much as cuts possible. But very often that alone will not be enough. It is great to deliver drugs because you cut and allow it deep penetration of the drug, but it's not going to give you a very nice lumen. Very often, if the tissue is become very hard and dry, cutting balloons are not going to be enough. You may need a high pressure balloon like Dr. Barua has said. I've had instances when I've done multiple cutting balloons, the chunk of the tissue has gone in distally embolized like a thrombus. So I think doing too much is also not good. You need to have 2 or 3 attempts at it, get the tissue squeezed as much as possible. So if you're putting a drug layered balloon or a stent, the tissue between them, old stent and the new layer should be minimum. And next, try to expand it and squeeze it as much as you possible at high pressures, and then do the DCD or a stent.
Girish, have you used IVL inside instant restenosis?
If I have had only 2 instances, sir. One was, very underexpanded stent in a calcified lesion, which had left ISR because the calcium was beyond the stent. Nothing else would have worked. And one I've used for a very old stent where there was a calcium inside the ISR segments. In both places, it did a fantastic job.
Dr. Sada, can I comment on it?
Yeah, please, Dr. Barua.
Actually, because IVL has come in ISR, I've done one case. Actually, that case has maybe 8 years back, it was done. It came a restenosis. And I did kind of OCT. We found a stent might have been undersized a little bit, and there's a heavy calcification outside the stent, in the wall. So I did IVL and open well, but she had multiple perforation. This is the first, probably I was really surprised to see that after IVL that lady has got a perforation. I never had this kind of experience. Anybody has got experience because what I thought maybe this calcium outside the stent probably might have, because of IVL, that produces almost 50 atmospheric pressure. Probably some kind of spikes might have, perforated the outer wall of the artery, and see 3 perforation in a segment of about, 22, 23 millimeter.
So I
That's
mean,
experience.
there is no such correlation which has been noted with IVL.
Yes.
That if you try and crack deep calcium, perforation is something which is unpredictable. So maybe
Yes.
some splintering happened and these splinters caused perforation. Because for underexpanded stent, IVL is very widely been tested. There are 2 major registries. One is IVL Dragon, the other is IVL Smile Registry, and now you have an IVL Elka Smile Registry, Elka Dragon Registry. So they've all proven that in underexpanded stents it works well as long as you have a single layer of metal. If you have more than a single layer, it doesn't work because it kind of does not allow the acoustic waves to penetrate through. And this is a real problem, what you mentioned, that if you have a stent with a calcific milieu in the behind the stent struts, I think we should all not forget that surgery is still a viable option in stent related ISRs. And if you have more than 2 layers of stent already in place and the patient is coming back repeatedly, I think surgery is something which should be offered to these patients, because as Mehta sir was pointing out, that monkey is not off the back. It's just a little time the patient is off you. And what Girish was mentioning about chunks going down, so there are different kinds of restenosis that you get. If you stent it in a thrombotic milieu, you get a layered heterogeneous kind of neointimal hyperplasia where there is fibrosis of the thrombotic material. And generally, when you open these with the scoring, cutting, or high pressure balloons, there is some amount of distal migration of the tissue, because it's not purely neointima. There is a layer of organized thrombus which is there within it, which kind of moves down and makes it look very ugly. So, and I quite agree with the protocols which were mentioned, which are very nice, because you initially score or cut, because that gives you a hold, and then use high pressure balloons to expand. And that is the only thing which is going to help this. The larger the vessel you achieve, the better it is. So I have another question, since we are coming to the close, to Dr. Prashant. Between the cutting and scoring balloons which you choose, since reusability is a criteria, what decides the choice of balloon in your lab?
Actually, we have used both the balloons, the apata and the cutting balloon, reused rather, quite effectively. So a cutting balloon we have used at least 2-3 times. So it dilutes the cost factor.
No, that is correct.
Apata is, I think, reusable, much better reusable than cutting balloon. Cutting balloon, once we try to reuse it, deliverability becomes an issue, particularly in calcified vessels. Apata is a little bit better in that aspect.
I also have this fear at the back of my mind, because these etherotomes are kind of put on the balloon with an adhesive material. So there is always this fear that post ETO or whatever, what if the etherotomes comes off the balloon? So there, I have not encountered in my lab, but I have spoken to people who've had distal embolization of one of the etherotomes. So that fear, of course, stays.
Yeah.
And there's another good thing with the Aperta, is that it comes with a reprofiler. So if you open an end balloon, on the pack, there is a small tool which they've given. So you can put your balloon back into that reprofiler and go to high pressures and take it out, and the balloon will acquire a very good shape. And the good thing is that the nylon stripes which are there, they are impregnated with the balloon material. So there is no chance of it coming out. And they are about 015. We use 014 wires, so 015, and they are triangular. So what is good about these cutting scoring balloons is that they deliver force per unit area very high at a very small focal point, because the general perception is that if I use cutting scoring balloons, I'll have very horrendous dissections, but it's just the other way. If you use cutting scoring balloons, you'll have only type A to C dissections, because the force per unit area is going to very small 3 or 4 focal points, depending on the number of heterotomes or the stripes which are there. And the intervening area opens up. And if you give duration, the plaque gets redistributed in the intervening area. So unlike a NC balloon, which gives very high pressure circumferentially, and that leads to horrendous dissections. So dissections are much lesser with these devices. So I mean, one should use them as much as possible. And if you have a device which has the virtue of reuse, I think that should be kind of preferred. The only thing, the differentiator between cutting scoring or the Apartha is that Apartha has a little larger profile compared to the cutting balloon, but you should use the reprofiler which comes with the balloon, and that will help you regain the profile of the balloon and use it optimally.
Also, Aperta is available in quarter sizes too.
Correct, sir.
Yes.
So, like the Wolverine is also there in quarter sizes, sir.
A longer length also, 13 Aperta can come into a bigger.
Yes.
So
Yes.
I think one could use it interchangeably also.
Yes, sir.
Yeah.
Okay. Any other points from any of the co-panelists, speakers?
So
Sanjeev?
I have one question. So
Yeah.
the era of cutting and scoring balloons, where do you see the place for an OP and NC? I mean, what are the group of patients where you would prefer an OP and NC, or they're just interchangeable according to you? I mean, we've been using OP and NC. We've rarely been using OP and NC. You know, we primarily use cutting and scoring balloons, and it does the job in most of the patients. Where do you see the role of an OP and NC?
Yes. So, can any of the panelists take? Otherwise, I will answer this.
Well, I think the one advantage of OPN NC is that it's double layered. And therefore, the balloon rupture or perforations are uncommon, balloon. And one could go up to 30, 35. And I've had the rupture of the balloon beyond 35 in more than once. So I think any instrument that you find that is not responding, is not giving in the atmospheric pressure of 25, 26, then I think it is a reasonable approach to switch over to OPN. And again, in OPN, occasionally you can go beyond 35, but there I think you are always taking a chance of a rupture of the balloon.
I think ABM sir has very correctly pointed out. I mean, in a native vessel, calcific vessel, when you find that there is dog boning of 2.5, OPN is a tool to bail you out. It's a poor man's IVL. And
Yes.
In underexpanded stents, it is magical. It is magical because it works beautifully well. Well, I won't compare OPN and cutting scoring balloons head to head. The reason being that where there is a need to do a controlled plaque modification, cutting scoring balloons are going to help you. But if you notice that in these segments, the calcium plate is thicker, there is dog boning with these balloons, and you can't go to higher pressure, OPN will just bail you out. It's a very good tool to have in lab, and it's a blessing for underexpanded stents.
So in your practice, you never use OP and NC as a first line balloon after imaging. That is, suppose you imaged a vessel and you.
Saurabh, if you are imaging, then things are very simple. Then it is algorithmic. And I didn't want to open the forte of imaging because I have been an avid imager for close to 2 decades. So I don't want to digress into that. If you are imaging, your tool selection is very simple. We know, as ABM sir pointed out, the penetration of imaging is poor. So I mean, the message has to be in a manner that people, those who are not imaging, should also. So if you get into a situation where there is dog boning and your calcium is very tough, OPN is a blessing. Just undersized, use a 2.5 it'll do the job. It'll just crack it open. Only precaution is that go rapidly up to about 12, which is the nominal, and thereafter you keep climbing slowly in orthogonal views, looking at the dog boning, and you can go up to the rated burst pressure of 30, 35. And for smaller balloons, the rated burst pressure is much higher. And you have to wait at those pressures. You, as I was saying in earlier in my talk, that you have to wait, and it will oblige you. It will definitely give you very good results.
Are we nearing the end now, or
Yes, sir.
summarizing
Yes, sir.
state?
You have to summarize, sir.
All right.
We
Okay.
always look forward to
Now
your.
I'll tell you one. One particular situation which I think very challenging is when the tortuosity and calcification are combined together. That I think is very unnerving, because no matter what you use, I think you always, at the back of your mind, a little bit apprehensive about leading with major complications. So, what I would say that the strategy in such kind of cases is highly individualized. What you're going to do first, and know for all everybody here, and for those who are listening to me, that any angulation more than 60 degrees, and that I think very often are more prone to produce perforation or a ugly dissection with the root ablation. So that I think one can do, but it requires a lot of experience in ability to change the wire bias and whatnot. But let me start with the simple thing. Number one, calcified media are to be handled by very careful analysis of angio as well as your imaging information. If to put an algorithm is like that 0.5 millimeter thickness plate, 5 millimeter length, and the arc of 270 and more, would be that it is easily you would consider that atherectomy is going to be needed. And I think that is the one which will make your life simple. So learning an atherectomy is not a rocket science. I think I and many of us in the panel right now can proctor and go to the various centers and then teach them and remove the fear, artificial fear. I think, this is a stage wise. I think following the atherectomy, when it is started with, one could go with the cutting balloon, or one could go with an OPN depending on the need requirement of high pressure. But usually, I think without the stent, to go very high pressure is, I think, not desirable. Your strategy should also include the upgrading the root upper. And believe me, once you realize that now at 10 or 12 atmosphere, the lesion is openable quite easily and fully expanded balloon is achievable, then I think the lesion preparation is okay. Delivering the stent also is sometimes a problem, but now we have no time, but otherwise we could have discussed how the various kind of strategies you can use for a guide liner or a guide extension catheter, whether you want to do a anchoring balloon technique or you want to do a what they call is devouring balloons and whatnot. But there's those kinds of things for some other time. So DS, you please add whatever you want to add now, and then we can all break for the dinner.
Thank you, sir. Thank you for your words of wisdom. I think we all have benefited by your presence here, sir. I would straight on go and thank all the speakers, the panelists, and all those who have joined this webinar. I think it was very educative, very interactive. I enjoyed each and every moment of it, and I think we've learned a lot together. As said, we can call it an end, and good night to everyone, and enjoy your rest of the evening.
Good night.
Thank you. Thank you, Veiva,
Thank you so much.
bringing this around.
I would like to take a moment to thank each and every one of you. Thanks to all the participants as well. And a special note of thanks for Dr. A.V. Mehta sir and Dr. D.S. Chadha sir for sharing your expertise with us today. Thank you to all the panelists and speakers as well for giving us your valuable time. Thanks a lot.
Thank you.
Thank you.
Until we meet again the next time. Good night.
Good night.